adults with ALL historically have not fared nearly as well as kids with ALL. And some of the work that was done about 15 to 20 years ago by people like Wendy Stock and others around the world who looked at retrospectively at people who were between roughly 16 and 24 who could really walk into a pediatrician's office or an adult doctor's office. And embarrassed as I am to say it, those who walked into the pediatrician's office did better than those who walked into the adult office. These are people with the same age and the same biological characteristics. The reasons for that improvement in the people who were treated by pediatricians could have been the fact that pediatricians basically see ALL, and adult doctors, at least in the US, see a lot of other diseases as well, maybe not quite as expert at it. Could have been due to the type of people who are taking the mums to the pediatricians rather than those who walk in to the adult doctor's office, but probably had to do with the regimens. And what we decided to do was just copy our pediatric colleagues' regimen at Dana-Farber and apply it to adults from 18 to 50 who we see. And we found it was a little hard to give the regimen to people in the 40 to 50 age range, but below 18 to 40, it seemed to be superior than historical controls with the legacy adult type regimens. And that's been borne out by a national trial led by Wendy Stock using a similar pediatric-like therapy. And now we're taking the pediatric therapy one step further. We're trying to see if we can improve upon it by adding an antibody-drug conjugate called Inotuzumab. And that's a national trial led by Dr. D'Angelo, led by the Alliance. It's an intergroup trial where people will be getting the CALCG 10403 type regimen promulgated by Dr. Stock with or without Inotuzumab early on in the course. And everybody who's MRD positive after the Inotuzumab or chemotherapy that they're going to get during that randomized phase will then be assigned to blinatumomab should they still be MRD positive, because just recently blinatumomab was approved for MRD positive disease. So both the ALL and AML fields have moved very fast, and it's challenged our ability to design clinical trials rapidly enough to keep up with that.